All right. So a little bit of background, anybody who has seen these patients in the clinic know that a routine clinical MRI has little value in diagnosing long COVID. Sometimes we find nonspecific findings like white matter lesions and large perivascular spaces and or microbleeds if somebody had a critical illness, but often we don't have pre-COVID MRIs to compare. But some research sequences have found gray matter volume alterations in the limbic, orbitofrontal, and secondary olfactory cortices that are present in long COVID patients and may change over time. And lastly, there is preliminary evidence that I show here on my slide of hypoperfusion in the frontal, parietal, and temporal cortices. Anybody who's seen these patients know that they're very symptomatic. So our question is why? What's going on? Why can't we see it on a normal standard clinical MRI? And how do we get at that? Because we can't biopsy the brain. So our study aims were focused not just on the individuals with neuropsychiatric PASC, but on the individuals with specifically cognitive impairment. And this is often, as we know, associated with fatigue, post-exertional malaise, and dysautonomia. So we investigated for vascular hypoperfusion in individuals with cognitive impairment compared to controls who had COVID but recovered fully and had no PASC. So first I'll go over our neuropsychological testing results. So like I said before, in this specific group, actually that our controls we compared to a bank of controls that were pre-pandemic, so they were all COVID negative controls, which was different than our MRI controls. So we used the WHO definition of PASC, and the procedures that we did were an RDoC criteria, which is an NIH well-rounded based protocol. So they completed questionnaires and tasks assessing cognitive domains, positive valence, mood domains, negative valence, mental health domains, motor, and social processing. So the demographics were very similar between the two groups, except in terms of race, ethnicity. And this, again, we're seeing people that are mostly non-hospitalized a year out from COVID who have cognitive impairment, fatigue, mood changes, and headache. So the NPASC group demonstrated deficits in language, memory, cognitive control, and perception significantly across the board, as well as significant differences, worsened depression, anxiety, rumination, and apathy. And interestingly, we did not expect this. The NPASC group showed motor slowing in the non-dominant hand, so that'll become relevant a little later. Social processing was normal. So connecting that with our MRI perfusion imaging, we enrolled participants with just cognitive impairment and then prospectively enrolled controls who had had COVID and no PASC. We performed arterial spin labeling to measure parenchymal blood flows, cerebral blood flow, CBF. And we used the Harvard-Oxford Atlas regions to compare in this preliminary analysis. So our groups were comparable by age, female sex, and race. And starting with the preliminary results, this is a comparison of the NPASC group to the mean of the control. So the cerebral blood flow is the 0 line, little pointer, and then the red dots are our NPASC group. So here showed relatively decreased cerebral blood flow in the superior frontal gyrus, which is involved in working memory, spatial processing, and the non-dominant hemisphere, the right side, is involved in impulse control and modulates motor urgency. The post-central gyrus was affected as well, showing involvement of the primary somatosensory cortex and proprioception. The middle frontal gyrus was involved in the left hemisphere. The dominant is involved in literacy. And I know I can link these to every story I've heard from a patient. I can't sit down and read a book. I just can't do it. Superior parietal lobule is well involved. Attention and visual spatial perception. People get easily overwhelmed by stimuli, and they have poor ability to multitask and pay attention. In terms of the precentral gyrus, that's involved in the motor cortex. So in the left side, the precentral gyrus was involved, and that corresponds with the right hand non-dominant motor slowing. And then the angular gyrus. So these are all high-level cortical involvement in the parietal and frontal lobes. And a wide range of tasks are involved in the angular gyrus, including language, reading and comprehension, number processing, memory retrieval, complex systems. And lastly, the precuneus, which overlaps with the superior parietal lobe a little bit, and also has a wide range of tasks and networks that are involved in its function and can also be involved in memory. And I know a lot of people have heard that as well. Patient comes in and says, I can't remember the conversation I had with my wife yesterday. And interestingly, there is in migraine a gender disease effect, specific effect between females and males, with females being more affected, which I found very interesting given the female predominance of long COVID. And so for the right hemisphere, there's a lot of overlap. So bilateral hemisphere involvement, so the precentral gyrus, again, so the primary motor cortex, and then also the supramarginal gyrus, which was not involved on the left side. So that's involved in phonological processing, spoken and written language. A lot of times you'll hear patients, I lose track of my speaking in the middle of a sentence, I have word finding difficulty, the thought comes and then it's just gone. Again, the postcentral gyrus, so the primary somatosensory cortex, and also the lateral occipital cortex, which is involved in object recognition. And the superior parietal lobule, again, which overlaps with the precuneus, involved in attention and object manipulation. And the supplementary motor area as well, so it involves complex sequence task planning for movements and coordinating bilateral movements. So in conclusion, when comparing all of the regions, so the trends that I just showed you, this is the significant findings. So in the left hemisphere, the superior parietal lobule had significantly lower cerebral blood flow compared to our control group. So there's a clear trend of hypoperfusion in the left parietal cortex, which may lead to visual spatial deficits and episodic and semantic memory impairment. And the question I've thought about a lot is, why here? Why in this area, the frontal and parietal lobes? Are these hypermetabolic areas? Yes, it's the cortex, but there are more hypermetabolic areas, the hippocampi, the cerebellum as well. This is a vascular watershed region, so is the cerebral blood flow affected by the small vessel function in these areas? Is this anatomic damage? Not that we can tell, because the clinical MRIs are normal. We would expect to see scarring or neuronal death. Or is this a functional impairment that's reversible when you stop overusing your brain? We've obviously heard that from a lot of patients as they get cognitive crashing, cognitive fatigue, and they're just done after a certain point. And why the gender difference as well, which I haven't looked at in our subgroup, but I'm excited to, as we continue to enroll in this study and gather more participants. So the limitations are that it's preliminary. We have a small sample size currently. Ideally, we'd like to enroll 100 individuals to get sufficient power. And then there's no pre-pandemic imaging, which we hear a lot from other research outside of long COVID, but it's an inherent issue that we deal with in long COVID. So I'd like to acknowledge everyone again in our wonderful MRI center at Yale for the support. Thank you.